I will now talk about my approach to MDS management. It's a rather generous title, allowing me to be quite personal, I would say. So I will base this on the European recommendations and a bit on how we actually deal with it at our department. I will first show you some curves from the Swedish INCA register. So in Sweden, you know, we have this cancer register since the 1950s, and it's actually complete for most cancers, and it's complete for MDS. It's nothing that you opt in, you just have to be there. And then, based on the cancer register, we have, for many of the diagnoses in Sweden, and for all the hematological main groups, we actually have quality registers where we also have data on blood values and cytogenetics and outcome and so forth. So this is actually all patients with MDS in Sweden between 2009 and 2014, includes also mixed MDS-MPN categories. So here we have 2,089 patients, and it's a 95 coverage against National Cancer Register. And I show these curves to sort of set your mind that this is really difficult diseases, and they really have a poor survival. It's easy to think that they are quite like the MPNs that we have heard about earlier today. But if you look at these four curves, where the red one is the low risk according to the IPSS, the blue one in the middle are those without cytogenetics, that we don't really have an IPSS. Even the intermediate one curve has a median survival of less than 3 years. And if you look then to the other side, we have the relative survival for these curves. So we can conclude there is no MDS that really has a good prognosis, really. So that is one of the starting points. If we then look at patients below 70 years, which is then the orange curve, you can still see that the median survival of patients below 70, irrespective of risk group, all risk groups together, is about 3 years. So the question is then, is this good enough for anyone with MDS? So this is also something to keep in mind. If you look then at the age distribution of MDS patients, and then you can see to the very far right, you have the very dark blue, these are above 90, and then you have the next color is 80 to 90, and then you have the middle blue color, and that is 70 to 79. And here we have patients where we today transplant quite a lot. I wouldn't say that up to 75 is standard at most centers, not even in our center, but I would say that the big centers fairly easily evaluate patients up to 72, 73. And if you then make a red line, approximately around this 72, 73, then you actually cover 40% of all patients with MDS. And to be provocative, I would like to say, is it possible to aim for a cure in 40% of patients with MDS? I'm not saying that is the case, but I think it's good to keep this in mind. I know that you have been discussing genetic aspects of MDS yesterday, so I will not take you through this. Just to remind you that appearance of clonal mutations in MDS mostly speak for an unfavorable prognosis, TP53 being the really bad guy, but also a number of other fairly common mutations, RUNX1, NRAS, ASXL1, IDH2, ESH2, and so forth, are speaking for an unfavorable prognosis. It's only SF3B1, common in ring sideroblastic anemia, that actually allow us to say this is actually better than having no mutation at all. So this is the current algorithm for treatment of MDS, published some years ago, based on the ELN work, led by Luca Malcovati, myself, Theodor Witte, and others. And this is the intermediate to high-risk IPSS. And I think you know this. We don't have at all the amount of drugs that you see in myeloma and in the lymphatic disorders, not even an MPN. So basically we have transplantation, we have azacitidine, EPO, lenalidomide, and we have the immunosuppressive agents. And what are the main challenges? I think this is my main challenges. That is to think stem cell transplantation for all newly diagnosed patients. Just give it a thought. it takes about 1 second to say that this lovely 90-year-old lady with sideroblastic anemia will not be transplanted. But I think the problem is if you don't think it until the patient has progressed, because then you are talking about a much worse outcome after transplantation. And how are we going to deal with this? And how should we move on to have better curves in 3 years or in 5 years from now? Well, one thing is that we have to improve the outcome of stem cell transplantation, allowing us to give it to elderly patients and to perhaps less fit patients. And we have to develop new pre- and post-stem cell transplantation strategies and protocols, making allo more like part of a treatment schedule than something very separate. I think we have to learn how to use azacitidine or decitabine for that sake, according to mutational profile and other clinical variants. I do think that conventional chemotherapy has a role in a few patients, perhaps not in the majority. And we have to improve primary efficacy of azacitidine by addition of new drugs sequentially or in any other way. We need new drugs, of course, too, and that will be covered later in this session. So how do we then, at our department at Karolinska, manage a potentially curable patient with higher risk MDS, or an intermediate patient where we think it leans towards higher risk? Very important with the multi-professional conference. This is not an easy diagnosis for many pathologists. We need an expert diagnosis. I think the pathologist involved should see a lot of MDS patients. And we need a proper risk assessment. What we do since 2 years from now is that we do targeted sequencing in all patients that are basically below 75, and also in the patients that Austin talked about, where we don't really know what it is. So we do it in Lumina TrueSight panel. It's 50 plus genes, not all of them work, but approximately 50 genes. And then when we are done with this, we start, or sometimes even before, we start first-line treatment, azacitidine in the majority of patients, but induction chemotherapy in some of them. And in parallel, we start azacitidine or treatment, and then we start to assess the possibility for a stem cell transplantation by searching for a donor and by medical assessment of the patients. You don't need to wait with this until, you are ready with azacitidine. You can do the checkup of an echocardiography with a spirometry, check dental status, make the patients actually fit for a transplant decision so that you don't have to wait. Because we know that some responses in MDS can be of very short duration, in particular those with high-risk genetics. And then what we do is that we evaluate the first-line treatment after 2 or 3 cycles of azacitidine or after the first chemotherapy cycle. And we are prepared to change strategy. Sometimes there are patients really relating a very poor outcome at azacitidine failure, but I think that is when you really go on for a long time. And if we then do the evaluation and switch therapy in both ways, we do as much switching from AZA to induction as we do from induction to azacitidine, and I think we see as many second-line responses in both of these things. So we switch early. And when we think we have a good enough response, we have a conference with stem cell transplantation and MDS doctors together with the patient and the family. And we also are more and more, based on the availability of new cell therapeutic regimens, actually plan for the post-stem cell transplantation strategies. So this is how we deal with higher risk MDS, basically of any sort. So then then I will go to the more lower risk, although these groups can also contain high risk patients. Again, back to the register, to the INCA register of Sweden, and anemia is the most common symptom. I will not talk about thrombocytopenia and other penias today. And if you look at the MDS and MPN groups in these 2,000 patients, 50%, about 49% of patients are actually red cell transfusion dependent at diagnosis. And in the MDS MPN category, where the majority has CMML, about a third of these patients. And we know that anemia and MDS is clearly associated with reduced survival, increased morbidity, and reduced quality of life. Here, the decision-making is more difficult, And this is my sort of general slide when I say how will we think, how will we actually address anemia in patients with lower risk or low risk MDS. And I think that we have to look at the erythropoiesis, whether that is hyperplastic or hypoplastic. We have to look at the general bone marrow cellularity, hyperplastic bone marrow, hypoplastic bone marrow that we heard about before. I do agree with everything that Austin said. We have to check the mutational status, and of course, we have to look at the cytogenetic aberrations and the number of blasts. And then, by doing this, we need always to take a very careful case history of the patients and think whether we have a potential possibility of a germline disease, and then we have to assess patients for that. Okay. So here is the first case, and I will come through several scenarios. Here is a case where you in the middle see abundance of ring sideroblasts. We almost always have a hyperplastic erythropoiesis with these ring sideroblasts. We often have a hyperplastic bone marrow, but not always. We have an SF3B1 mutation in 80 to 90% of these cases. We have a low bone marrow blast percentage. So what do we do then? Going back then to the European guidelines. How do we treat IPS as low risk with ring sideroblasts? And I would like to say then, in patients below 75, we do the targeted sequencing, because also in this group you may have the finding of poorer risk genetics. A few have actually TP53 mutation. They are usually not having SF3B1 mutation, but you can also find RUNX1 mutations and other mutations where you are fairly sure that this tips the patients toward the higher risk. If these patients have symptomatic anemia, the first-line treatment is erythropoietin. If you have the low serum EPO and the sort of symptomatic transfusion requirement, most patients have that today. I mean, with early patients, they have low serum EPO levels. And then EPO plus minus G-CSF is the first-line treatment. It works really well. Second-line treatment here is everything is within controlled randomized trials. I think we will hear more about luspatercept from the next speakers in this session. So why is this important, and how do we think? And now I will just show you one slide, a recently published paper from the European Leukemia Net EU MDS register, where we looked at a lot of patients that were exposed or not to erythropoietin. And we had, I think this paper is worth reading, because what we showed was that if you expose patients to erythropoietin stimulating agents early on, before the onset of a permanent transfusion need, the time to the first transfusion is actually significantly delayed, as shown by the left curve. Also, survival is actually impacted, but it was not significant in this first analysis. And if you ask countries in Europe, when can you start erythropoietin treatment? Many countries say that the authorities or the reimbursement system doesn't allow us to do this unless after the onset of a permanent transfusion need. And this is actually wrong, and we will try to build this into the next guidelines, because patients started just when they sort of are symptomatic, below 100 or after one transfusion, they can actually respond for very long periods, sometimes up to 10 years, without the need of blood transfusions, chelation, and whatever. Okay, now we come to the next scenario. We have something that you recognize, the del(5q). Ari Guanidis will talk more about that in a minute. Low bone marrow blasts, mutations, I will come back to that. Cytogenetic aberration, including del(5q) or only del(5q). Very often a hypoplastic erythropoiesis and a normoplastic bone marrow. And what does the guidelines say? They say symptomatic anemia, first-line treatment is EPO G-CSF. These patients respond as well, providing they have the right sort of risk factors. But if they stop this response, second-line treatment is lenalidomide. This is what we say in the guidelines. Is this something that we would like to see for all patients? And then I would like to just give you some caveats. This is the original MDS 004 trial, starting at time point 0 with transfusion-dependent patients refractory to erythropoietin and G-CSF. And these are the survival curves divided onto those that respond to treatment according to the trial and to the non-responders. And non-responding patients to lenalidomide, if they are transfusion-dependent up front, is actually very poor. 2 years, that is a high-risk disease. But I would like you to look at the responding curve, which here the survival amounts to something between 4 and 5 years. And if you are 55, 60, even 70, you would like to live longer than 5 years or 4 years. So why is this the case then? It is probably because some of these patients have acquired genetic events, mutations that make them no longer be a perfect low-risk patients. Based on the same cohort, the 004 cohort, 85 patients of these where we actually could find bone marrow biopsies. And the TP53 mutation in this cohort, as this study didn't allow sequencing, was actually by immune histochemistry for P53, which is a good actually surrogate marker, these black, very dark positive cells. And about a third of these patients, actually 1/3 of these patients, carried small mutations, usually in the size of 1, 2, 3, 5, less than 10%, not detectable by Sanger sequencing. And these patients, looking at 5, 6 years post-start of lenalidomide, had a leukemic transformation rate above 50%, while those without P53 mutations actually fared much better. This is a recently published study in Hematologica where we looked at 35 patients from our own cohort. They were non-randomly allocated to lenalidomide or other types of treatment. And if you can see, here. These are the lenalidomide-treated patients. These are those that did not receive lenalidomide. And here are patients that actually lost response or progressed during Len treatment. And here we have the pattern differs between those that still respond and those that were not treated, because these patients have, as we expect, P53 mutations in a large majority of these cases, but they also carry RUNX1 mutations. And a bit unexpectedly, but perhaps not so when you see new data, quite a few of them also actually had acquired TET2 mutations. So somehow the clonal instability in del(5q) is marked if you compare them to other types of lower risk MDS. So this is something to look upon. And then when we go back to this slide, so what we do at the Karolinska, if they have lost their response or if they're ineligible for EPO G-CSF treatment, and if they are transplantable, we actually transplant them directly. I don't think the outcome or outlook for these patients is very good. And even if we want to give them lenalidomide, a second-line treatment, we nowadays check for the targeted sequencing before we actually take this decision. Okay, so now we have younger patients. I will be very quick on this because this we heard from Austin. No ring sideroblast, perhaps they have these clones, low bone marrow, hyponormoplastic bone marrow, normal karyotype, and ATG plus minus cyclosporin A could be a fantastic treatment. I have in my office, patients who have treated in 97 based on the first papers, and they are still alive and well, and I don't think they really have much disease left. But then we have this disease, which I find extremely interesting, for which we have very few good treatments today. And these are patients with hyperplastic bone marrow, low bone marrow blasts, extremely hypoplastic erythropoiesis, and very often a normal karyotype. And now I would like to show you, these are MDS, MPN, classified CMML, but also RCMD. And I will show you a patient. This is a patient from last fall, 72-year-old. Her MDS is therapy-related because she was treated for breast cancer some 6 years before. She came in severely transfusion-dependent upfront, good neutrophil count, fairly good platelet count, extremely high bone marrow cellularity, no blasts, 1%, multilineage dysplasia. She gets a diagnosis of an RCMD, almost no erythropoiesis in the bone marrow, and a normal karyotype. And when we then look at the IPSS, she scores low in the IPSS, and also low, not very low, but low according to the IPSS-R. So she doesn't get a lot of points here. And she has a high serum EPO. She's not eligible for erythropoietin. And we do the myeloid screen on these patients, and she comes out with 2 poor prognosis mutations, although not a very worse with P53. AXSL1, ECH2, she has a KRAS mutation, and she has 3 TET2 mutations. What you see to the right is the scoring from the geneticist. Pathologic means pathologic. You can understand that. Troligen means probably pathologic. Okay, so how do we treat her? We recently published together with Austin and with Gula Mufti and the Karolinska a cohort of around 134 patients treated with azacitidine, the majority according to the European label. They were high or intermediate 2 risk. And I will only go through this because this has relevance. When we looked at the role of the presence or absence of epigenetic mutations, TET2, DNMT3A, the histone modifiers and so forth, there was no difference in survival following azacitidine with the 2 groups. And importantly, we didn't look at response rate because I don't think that is very relevant. The relevant thing is how long do patients survive post-azacitidine treatment. But when we then looked at histone mutations, we saw a significant difference between patients having these mutations compared to those not having these mutations. So usually in untreated patients, these 2 mutations shift the curve towards the worst. In azacitidine-exposed patients, these mutations shifted the curve to the positive side. And we were in fact able to make a score, which I really would like to see validated or tried out in independent systems. So the red curve here are patients without adverse cytogenetics, but with presence of these histone modifiers, mostly then AXSL1 and ECH2. These were patients without these mutations, but with adverse cytogenetics. They can, as said, have short complete remissions, but they never are durable. And these 2 curves in the middle was when you actually had 1 of each. So it was better if you had adverse cytogenetics to also have these mutations than to not have it. And in these patients, you see survival post-start of azacitidine of 2.5 years, which is not too bad. So we treated this woman with azacitidine, and here you have the outcome after 3 cycles of azacitidine, where all these clones actually went from significant to not detectable. So she had a very strong effect on the malignant clone. If you look at these 2 TET2 mutations, one didn't decrease much, and one actually appeared. And most likely these are something that she had before the onset of a full MDS, some kind of clonal hemopoiesis. So back to the summary then, treatment of anemia according to clinical and genetic features. I think we have to ask the question about germline and look at all these. Do the mutations, cytogenetics of course, these are general things. Think about sideroblastics or not, and look to see whether the bone marrow is hyperplastic or hypoplastic. That requires then a bone marrow biopsy. So this is how we at the Karolinska actually apply the European guidelines and new data. I think we will have much more to say about genetics and also immune diagnostics in some years from now. And with that, I would like to say thank you.